Robotic surgery has had a tremendous impact in my field, where we perform transoral robotic surgery to treat cancers of the tonsil and the tongue base, and also the supraglottic portion of the larynx. The reason for this minimally invasive procedure comes from what we were doing before 1990. At that time, we had to perform a lip split and a mandibulotomy to access the oral pharynx, and of course this was very difficult for the patient to overcome. The recovery was difficult. It required feeding tubes, tracheotomy tubes, and there were also problems with healing, development of a fistula. So in 1990, because of some work that was done at the University of Michigan, there was a change in the treatment patterns for the patients with oral pharynx cancer, where they would receive chemotherapy and radiation as their primary treatment. This had great oncological outcomes where they were able to receive good cure rates for these patients. However, it came at a significant price. That is, the resulting scar tissue that forms in the pharynx after the combination of chemotherapy and radiation made it extremely difficult for patients to swallow. And therefore, many of them ended up relying on feeding tubes or had to have a significant change in their diet in order to accommodate the dry mouth and the swallowing difficulties. There were a group of surgeons who gathered in the end of 2006 to talk about using the robot, which could be used as a minimally invasive tool to place the instruments in the mouth and to operate on these patients so that they would not have to undergo chemotherapy and radiation. And so 3 institutions took the lead. The primary institution was University of Pennsylvania in Philadelphia, also the Mayo Clinic in Rochester, and University of Alabama, Birmingham, which was my institution at that time. And in March of 2007, we began performing transoral robotic surgery to treat patients who had tonsil cancer and tongue-based cancer. We did this together as a group. This was a research protocol that was approved by our hospital institutions, and we collected the data prospectively for these patients so that we knew that we were doing something that was safe for the patient and could provide an optimal operation for the patient, removing the cancer and providing them a chance for cure. We gathered our data together in 2009, and that was submitted to the United States Food and Drug Administration, or the US FDA. The US FDA took about 9 months to look over the data to confirm that this was a safe operation, and finally in December of 2009, the US FDA approved transoral robotic surgery, or we call it TORS, for the treatment of cancer of the tonsil and the tongue base. After 2009, it became available for all surgeons then in the United States to perform, and there was a dramatic adoption rate for transoral robotic surgery for treatment of these patients. It has now begun to shift the pendulum completely away from chemotherapy and radiation back to treatment using surgery, because we're able to perform minimally invasive approaches and not resulting in the terrible disfigurement that was done before with open surgery. What we're able to find is with the same cure rate as chemotherapy and radiation, we're able to decrease the postoperative or the post-treatment symptoms. That is, there's less reliance on feeding tube with transoral robotic surgery. There's a quicker return to work, there's less hospital time, and even some studies show that it costs less if you undergo transoral robotic surgery instead of having chemotherapy and radiation. So that's the background and the impact that transoral robotic surgery has made on patients with this type of disease. The challenges we face with transoral robotic surgery have largely to do with space, and therefore the new robots that are being developed are addressing these issues. As an example, the robot companies are making instruments that are smaller. They're making machines that have a single port where the instruments can come out of the single port and enter a natural orifice, in our case, the mouth, transoral. It's also used for transanal, transrectal, and transvaginal, where we can take those instruments and go in through a single natural orifice. And so the creation of these new platforms for the robot will overcome some of the limitations we have with the robot that we use today. Additionally, there can be some advances in imaging, where we can have real-time imaging that can be overlaid on our surgical site. We can use ultrasound in real time to look at the tissue and the anatomy and the vessels while we're operating. And in the future, I see that we're going to be able to have instant access to the internet, to the web to obtain resources during surgery. The robot itself may have seen plenty of operations that it may give us some suggestions or help us identify anatomy. And so currently, the robot is simply a master-slave relationship, but I think in the future, the robot will have some of its own intelligence and some of its own information that can give to the surgeon to make the surgeon better at what the operation needs. I don't think that there will ever be a time where the robot is working completely independently and completely autonomous, because there has to be some ability to create decisions in the moment and also to choose the patient if they're appropriate for an operation. So while the robot might know the steps of the operation, it doesn't know the why we're doing the operation or the reasons for the operation. It may just only know the steps. Similar to the cars now that do not have drivers, they don't know why they are driving. It just knows the steps to turn, go straight, and you finally reach your destination.